points at the start. As usual, I would ask those who are presenting reports to take into account the fact that board members have read the reports in advance of today's meeting. So please just highlight the key points of the paper and draw attention to anything that might have changed since the paper was drafted. We are going to take a short break at around 11:30 this morning. So just to factor that in, I would like to offer a very warm welcome this morning to Gareth Roberts, consultant in anaesthesia and critical care. Gareth is here to present the listening and learning story at agenda item 3.1. A very warm welcome also to our newest independent member of the board, Cathy Mason. Cathy is joining us for her first public board meeting today since taking a post. Really good to see you this morning. Also, a very warm welcome extended to Claire Thompson, our Executive Director of Strategy and Transformation. This is Claire's first meeting of the public board since taking up her post in June. Also, a very warm welcome to Farhan Tajwa, who is on the Aspiring Board Member Programme with Welsh Government and is undertaking a placement with us as an observer at the CTM board. Farhan, terrific to see you this morning as well. Sarah Bradley will be joining us for items 6.3 and 6.3.1. Sarah is the Service Director for Primary and Community Care, and she'll be presenting those items in respect of the reform agenda that we are now leading around our primary care, community care system in CTM. Matt Jenkins, our Integrated Services Director from the RPB, is also going to be here a little later, item 7.1. And Daniel Price, the Regional Director for Place Cymru, is also attending the meeting virtually. So a very warm welcome to all those who are attending and those who are attending for the first time. I'll do the apologies for absence, and I've got then two very quick things to say about two members of the board who are leaving us after today. We've received apologies from Rachel Rowlands, Geraint Hopkins, Carolyn Donoghue, Dilys Juvenat, Lisa Curtis-Jones and Sally Bolt. You will notice in my chair's report a little later that two of our board members are retiring after today. Geraint Hopkins, our independent member with the local authority background, so Councillor Geraint Hopkins, who has been a member of the board now for almost 4 years, is leaving on the 1st of August. Very sad that Geraint can't be here today, but I just want to place on record my thanks for all that he has done for the organisation. Geraint's insights in local authority, the local authority environment in CTM has been invaluable. His knowledge of social care, having been a cabinet member for social care with Rhondda and Taf Council, again has been incredibly helpful in advising me and the board in some of those challenges and how we bring many of the things that we do across our health and social care system together. So Geraint has been great support. He's brought a certain flair to the board. He's been terrific in his support, and I'm sorry that he's retiring from his role, but I'm sure we wish him all the very best for the future. Likewise, this would have been Sally Bolt's final meeting as one of our associate members, but Sally, again, as an associate member, her term came to an end, and she will be replaced for hopefully for the next board meeting in 2 months' time. So again, my thanks to Sally for all of the advice that she's given, all of that clinical background, the staff background, the corporate knowledge that she's brought to the board has been incredibly invaluable as an associate member. And of course, we don't lose Sally because she's part of the team. But I know we'll miss her from her contributions to the board as well. Item 1.3, declarations of interest. I don't know if anybody has anything they wish to declare in respect of today's agenda. No, thank you very much. Item 2, the consent agenda. As to ensure that we are focused on those things that are critical to the organisation, we've got the consent agenda towards the back end of the meeting. However, if there are any other matters towards the end, particularly those that are there for approval, that need bringing forward, if you could just indicate now, that would be useful. Otherwise, I shall leave them where they are. Oh, okay. Splendid. Right. Item 3, our shared listening and learning story. So our story this morning is around the transition of care from paediatrics to adult services, and delighted to invite Don and also to ask Gareth as well to contribute to this particular story. We've got some slides. I think there may well be a video as well of a relative of the patient outlining the experience of the care they received. So Don, over to you. Thank you.
Well, thank you all for the opportunity to discuss this. This is quite a new area in CTM, of an area that we sort of started an initiative in, which is the transition care from paediatric care to adult care. I'll talk a little bit more in detail after it. I don't really want to sort of bias you into listening to the story. I want you to hear it for yourself and see how it lands, and then we'll have the discussion after, if that's all right with you. But I would just like you to just to think a little bit about, when you're listening, to appreciating the complexity that some of these cases have. We'll touch on a little bit more afterwards, but when you're talking about a single organ illness or pathology, such as respiratory asthma, quite in some ways relatively straightforward to hand over care. But when you have multiple comorbidities, it obviously magnifies it beyond that. So if it's right with you, I won't say much more at this stage. Let you watch the video, and then Gareth will then sort of pick up give you some points and answer some of your questions. Oh, excellent.
One of the parents of the young lady who
brilliant years around.
Sorry,
Yes, it's the pressure, isn't it? People watching it.
Yeah. We're all looking now.
Yeah. Look at me. Yeah. Blame the digital tech, you know. I don't know. Thanks, all right.
one of the parents of the young lady who was born with complex needs, she had myotonic dystrophy, but she went on to develop many more conditions alongside that. We'd always been involved in children's services, and we were due to transition to adult services. And we were quite fearful of that time, really.
She had really profound complex needs. She was blind, she couldn't talk, she couldn't eat, she couldn't walk. She had hereditary scoliosis, she had dislocated hips. So she was really profoundly disabled, but always happy. And we tried fighting like going to adult intensive care, because I think lots of parents, they all worried because they don't really know what to expect. So we really worried about how always.
Yeah, and transition is a bit mumbled, really. Some services you transition at 15. Some services you transfer at 17, some 16, some 18. So this transition is not so seamless. But the main bit, I think, for us was the acute services, intensive care and things, because we always knew that we would end up there one day, and it certainly wasn't if, but when. And I think lots of parents of kids with complex needs are also in very, very similar situations. In fact, sometimes we can have regular visits to intensive care.
I think the good part for us was that the consultant that was in charge of intensive care, she actually went to visit PICU in this basically hospital. She wanted to know, because she never looked after a child with such complex needs. She only cared for adults, and she wanted to know what the day-to-day when it wasn't being late and how they dealt with children with complex needs, because it's not just the one illness they're dealing with, it's just the whole of the person, every single part of that, our daughter. There was something wrong with every single part that she wanted to know really how she could manage that in an adult setting. So she actually spent a week, which was absolutely amazing, just learning all about curious children with complex needs. So and then the chap she came to our house to actually just talk to us about it and to speak to her experience and to allay any fears really about what would happen to our little one if she went to be intensive care. Yeah, and she was, you know, and she was really honest, and we spoke about end of life and what would be best for our little one, and you know that she has turned over. So I think that was a big positive.
Was, yeah, and it wasn't just going to Cardiff to find out what they do. It was to find what she could do that would be better. What she wanted to do was improve upon the services, but also during that early phase, which was so important, she was able to introduce us to the intensive care environment. They became very aware of us. So when we did go there, it wasn't, we weren't walking into a strange setting. We knew exactly what we were walking into. And they were also very aware of us, which is obviously massive, really, that to have that familiarity made many fears that we had. And maybe to the point where picking to spend a week here in the adult intensive care to learn what they do. And it really was. Obviously, it's a sad time, incredibly sad, but it was, we look back, this, I don't know if this is the right thing to say, but we look back on that sad time with happy memories. And we do have happy memories from that time.
Thank you very much, actually, for having me here today. I presented this locally at our directorate meeting because this was a really, really brilliant example of what we do often. We give really good care, and I think the health board does celebrate it well overall, but most days we're dealing with things that could have been better, these sorts of things. But this case here was an absolute pleasure to deal with. And it was really, really aligned to the health board values. And I don't want to sound like a sycophant about the health board values, but they are really very good. And day in, day out, I remind myself of the health board values because they're so easy to think about and to work to. And I think if we all did that, we will keep moving forward and doing really, really well. And this case here, I can't explain the complexity of this. I call her a little girl. This patient was an adult, as you know, that's why she came to us. But she was told she would only have one Christmas, and she had 18 Christmases. And this is how we're going to be seeing more and more of these complex children moving into adult services. Medicine is making people live longer, so we are going to be seeing more and more children moving into adult medicine. And as Dom said, if it's a single organ problem, that's a bit easier to look after. But as the father said on the video, the PEDS are not terribly aligned with regards to social services at this age, learning disabilities at that age, medicine at this age. It's quite fragmented. And the end bit there where Gary was saying that his daughter died at the end of this, and yet they have happy memories. And that's the bit for me where they never left her bedside up until she came to our unit because that was their life. They always stayed overnight. Because they knew her so well. And that was the case when she was first with us for a few days. But because of the work we had done in the lead up to her coming to us, and again, this is preventative medicine, and we all know that we want to prevent, not react all the time. They trusted us. They knew who we were. We knew who they were in principle. We already had that planning that was done in a cold, calm setting. And so when actually this patient came to us, we didn't want her to be so sick that she needed to come to us, but it was going to be inevitable at some point. They didn't want to see her in an intensive care unit, but we had to make the best of a very, very terrible situation. And yet they did start going home each night. And so having that belief and trust in the service we were providing, and they were believing in us that we were doing as we said we would, and that those communication streams and the interaction with them meant that they went away from all this happy. And then there's things you can't measure. They're still active in society. Their health is better for it because they haven't got these terrible, terrible memories of their experience with us. And I will link it into the values because I think it's a brilliant, brilliant example. So the team working and the respect aspect. It was quite serendipitous, I'll be honest. This young lady used to have a respiratory support machine as a paediatric, when she was under paediatric services. And it was only because the parents said, what happens here with this respiratory machine? You know, because when she goes to adult, what's actually going to happen with that? The paediatrician said, yeah, okay, yeah, we should probably link in with someone. So they asked the right questions and they did push for peds to link in with us. So it wasn't by design. I think that's why it's important we present this to the board today, because it wasn't by design. But the teamwork and the respect was excellent from that point, because the referral came to us. One of my colleagues took the case on, as you heard them saying, she felt that she needed to take some time to go to the paediatric intensive care in Cardiff, just to see a bit more of it. So we arranged that. She spoke to us, she spoke to our anaesthetics colleagues with regards to cross-covering, and we released her on study leave at no cost. It was all perfect, SBA at its best. And she came back having learned loads. She met the family with regards to what do you understand about the condition, what do you think an adult intensive care looks like. And that was showing respect for the fact that we all use the same language in medicine. Doctors talk to each other in the same way. We use a common language with nurses, etc. We have to talk slightly differently with our non-clinical counterparts. But when you're talking to people in the community, you've really got to establish what is their background. They may talk the same language, so they may have no idea. So you have to work that out. My colleague did a brilliant, brilliant job at working out what they understood, what they would like the future to look like. And did they understand that even though they were told there'd only be one Christmas and they were 18, those Christmases are going to, it is going to come sooner or later, that is going to be a short life. So there's a lot of background work that was done. And we were sharing that information, and that was real joint ownership of the plan. When this patient needed to come to us, well, no sooner did she turn 18, she was with us. And it was my week on as the duty intensive care consultant. And it was a busy unit with lots of other people who also had their own needs. And everybody needs the time from me to work out what they need, etc., etc., in each bed area. I would have done my absolute best for this person, as I'm sure you know, if that hadn't been done beforehand. But my life was made so much easier. And the communication with the parents, the language we were using, it's as if we already knew each other. And it made a terrible outcome really, really good. And they wanted their child to be at home when she died. That was the plan overall. When it came to acknowledging the dying process, they were happy for her to stay with us. So she died in our unit. And yet they were still went home with happy memories. So I think it's just brilliant. We can't get it as right as that all the time, but it was the listening and learning aspect of it and improving is that it piqued my interest because this was by serendipity. And I feel that we need to somehow get a bit more of a process in place, because this is only going to increase in time, the numbers of people we're dealing with like this. So I presented it locally. I wanted to really congratulate everyone. It was just a brilliant, brilliant example. And I discovered then that Don was actually doing some sort of transition of care thing. And of course, when you're in a big organization, you don't know who's doing what. So again, bit of serendipity, but brilliant. So thank you so much for having me here to tell you my aspect of it. And I am a big believer that the learning and improving doesn't only have to take place after something hasn't been done terribly well.
Yeah.
You do something well and you celebrate it, and you bang that drum, you shoot from the roof, shout from the rooftop, and you work out, well, how do we improve upon this? Because there's always things you can do. What have we learned from this, and how do we make sure that the next person that comes along with these complexities, hopefully then, by design of the system, gets a similar outcome? Does anyone have anything to ask? Because I will talk all day, so I sure need to keep me to time.
That's fine, Gareth, honestly. Dom, do you want to come back in?
If I quickly just do my summary and then
Right,
and
yeah.
look, thank you again. As you, I think I don't need to add much more to what we're going to say, because as Gareth sort of said, it's trying to move away from that, the individual flags coming up and, oh good, we've managed to pick this up, oh we haven't, there's a gap here, to actually doing it by design, so how we do it. And that's what we're trying to do in CTM. There is a national drive across Wales now for transition care to become central. That's by the Cabinet Secretary. It's about time it's come. Cardiff Vale have been running it for a while, and so they're a little bit further ahead of the curve. We are most definitely the next health board, way above everyone else, because we've started a process of how do we start documenting, having a shared document for the one patient where everyone contributes into, so it's all in one place, so they don't have to continue to repeat their story when they see the gastro team, the respiratory team, the mental health team. So we're working on that process through. We're looking at setting up our own sort of youth council as well within here to help advise and direct that through. So there's a lot we're doing, but I'm not overly content with the fact of, oh great, well we're doing really well across Wales. It's not good enough because we just don't have it in place at the moment for all our patients, and it's a really complex one. How do we start moving to having comorbidity clinics where on a Monday morning we have all the teams present, as opposed to this particular family? A good example, they come in on average about 3 or 4 times a week to see a different team each time.
Yeah.
And it's things like that we've got to start thinking in a very different way around these patients, about how we sort of actually manage it for a better care for them, better care for the patients that we have. And it's scary going from being this. In paediatrics, you are very wrapped in cotton wool. You're looked up. It's about the family involvement discussion. It's the whole team together. It's a lovely environment. Suddenly you move to adult services, and where you talk to the individual, you're on your own, we'll support, but it's much more an arm's reach support. And that is extremely scary for these parents when they're trying to manage these sort of cases that they move through. So we are doing a lot. We kickstarted the programme now. It's been run by the Child and Family team. Susie Hardacre is the main sort of lead for this. Shika Jane, who is our CD for paediatrics, is heading up a task and finish group of looking at all the issues that we have to put everything on the table. What is it we've got to do? What are we doing at the moment? How do we collate and pull it together? We're trialing this new documentation, see how that works. So it's going to be something that's going to happen quite rapidly over the next 6 months. Hopefully within the year, we'll be able to come back to you and say, this is the program we've got in place. This is how we're going to do it.
Very good. Yeah, thanks, Gareth. Really big experience. And as you say, really encouraging, I think, to your point about using positive experiences to drive improvement. I guess a couple of things for me. I mean, what's interesting with this case, isn't it, is that this young lady had a multitude of challenges. So obviously would have come into contact with a multitude of different professionals. But candidly, we don't even get it right always for somebody who's just got diabetes.
Absolutely.
So, it isn't just a case of it's the multiple comorbid patients that need this. It's actually, if you're a 17-year-old with diabetes and you're moving to adult services, as Don said, you feel quite protected because you've had the same clinician perhaps for 10 years dealing with you, and suddenly you're told, sorry, you've met a threshold, and now you're off into the general melee of adults and different phone numbers, different medical teams speaking to.
Absolutely. And I think actually, starting with the simple steps, you said that single organ problem like diabetes or respiratory condition, get it right with that, then hopefully it should go from there. So it doesn't have to be, as you said, just the complex patients, because if you're not doing it terribly well with just the initial transition.
Yeah. And a couple of other things I'd say is, if ever there's an evidence as to why you need electronic patient records, these sorts of cases are they, because I can guarantee you that young lady will have had a record in physiotherapy, a separate record over in OT, a separate record in paediatrics, a separate record somewhere, etc., etc., etc. And of course, trying to get an overview as a clinician of what's going on for this person and who are the people involved in that world of paper records and disparate paper records is really, really challenging. And the other bit, I think, Dom, just thinking about the bit of work doing, it's great to hear that we're sort of involving young people in those sort of thinking, because we can sit here and think, what does it feel like to be a patient or a relative dealing with this? But until you've actually sat and talked to those families, and in some ways, the service we design should be the service that they tell us we need, not what we as a collective group of professionals think would be a good thing. And one of the things I always think works quite well in these experiences, and having had some of this experience on a personal level myself also, is having one named person who's a coordinator, and it could be an OT, it could be the paediatric nurse, it could be the consultant, but somebody who is their like go-to person who can say, leave that with me, I'll go and chase around and find that out for you. Because otherwise, if you're a relative, you've got to try and navigate your way around all these different services. People don't know you. So how we use that experience to drive that model of transition, I think is really
and that's a common theme, Paul. So you hear it time and time again, and they would describe, as Dom said, they come in 3 times a week. If it's a respiratory problem, and ask the gastro question, oh, can't go near that, you'll have to wait to gastro. And they didn't know who to go to and when. And it seems like a very simple thing, I'm sure it's not, but it's a recurrent theme. So again, by design, you almost need to have that named person, whether it's an organisation thing we do here, someone who follows us. But absolutely.
I absolutely think that care coordination for these patients is really, really, and the families, not just the families need it as much as the patient needs
so
it.
we have coordinators at the moment, but we have 1 day a week for one person. It's no way even close to being it. So that's where we exactly where we need to start and best. So the interesting thing about this one, the example that Gareth has said, is when it comes to medicines as well, is that you give sort of switch medicine that has an knock-on effect for gastro, and the gastro needs to give an opinion as to whether what dose you give. 6 months down the line, families still don't know what dose they should be giving, whether they should be giving it or not. It's ridiculous small detailed things like that.
And I think the thing is, we've got to be careful of here is that obviously many of these young people have involvement in social services as well. Now, there is a temptation that we say, well, the answer is health and social services. And I'm just thinking we're having a similar conversation in the adult services agenda about how we integrate more health and social care services for adults. But what we've also realised as a health board is we've got to get our act together first before we almost integrate with anybody else. So let's not get, I mean, no disrespect to college and social care, they need to be involved. But in terms of designing that model, let's get our bit of the equation sorted first. And then it puts us in a stronger place to go to social care about how do we now get this. Otherwise, we're trying to solve everything in one place.
There is a higher proportion of complex patients who are under foster families, in foster care, through local authority involvement, and that makes that a whole other level of complexity on top of it as well. So, but you're right, we need to sort our bit out first, and then we Lauren.
Thank you for that. That was great. So thinking particularly, well, I'm thinking about mental health services actually. We know the evidence shows there's a significant risk, isn't there, at the point of transition between children's and adult services. So grateful you mentioned, John, that it's and services. And then it also made me think we had a great patient story at I think it was Quality and Safety Committee recently with the carers link person that we've got in the organisation. So coming back to what you said, Paul, that importance of getting people's experiences and their frustrations. So the carer that came was great and listed a whole host of things that in isolation would have been really frustrating, but they're managing those day in, day out. It happens again and again in services. So it must just be exhausting. So I think we've got to link in the carer work, haven't we?
Yeah, definitely. That the one thing I will say, and I should have said right at the beginning, that the CAMS team are way ahead of any other specialties that we have here on this. They are, and understandably so, but even they need help to
And
take to the next level
as well, mental health.
Exactly.
Patty.
Yeah, just a question around who you address in your conversations to, because when they're a child, it's the parent, but when they're an adult, if they have capacity, then it's the patient. And this came up in the carers thing as well, didn't it? But that must be really difficult, both for the parent and judging capacity.
It comes into when you have the learning difficulties factor into it, becomes very difficult to talk. Or in some ways, it may be slightly easier. It's very much individual though, and in some cases, you have a patient might come in who's 16. I want to go on the adult unit. Thank you very much indeed. I don't want to be about paediatrics. I want to be spoken to, and they have the right to do that, and that's fine. Others want their parents involved, and they might go down the paediatric route for 2 years or so. So it's trying to tailor it to what that particular individual needs, based around what the individual rather than the parents, although the parents have been so integrally involved for so long, you can't just suddenly go, oh, well, they're adults, not talking to you anymore. So it's how we do that, how we address that, needs to come through this process. And that will be through the paper as we work through the discussion. What do you want when you transition? How are we going to do that for you? I want my parents involved for the first couple of years. Fantastic. So it needs to be done.
That's done. Catherine?
Yeah, Gareth, thank you. A very sad but heartwarming story of really thinking about that individual. And I guess thinking particularly of the complexity that we were talking about in this case, and you know those children that are on our caseloads now who will move in this way. I guess there's something for me around no, because part of the complexity with that is of course that they're receiving a lot of their care in UHW or potentially Bristol or other providers. So there's something about what we can do with our services, but also and I don't know what the right answer is, but there is something, isn't there, about that, you know, the support that you gave to enable the individual to go off to PICU, spend that time, understand and build those relationships. And I guess there's something, you know, we know who that caseload is. We know who those children are that are going to be moving into those in tipping over into adulthood over the next 12 months, 18 months, 2 years. And I guess, you know, in that spirit of let's celebrate when we do something. So how do we make what you did normal process within CTM? And you know, is it and I don't know what the right answer is here, but actually is it that, you know, particularly where there's going to be a need for ITU involvement, is it that something that we offer on all our ITUs, or do we actually say, well, actually one of our ITUs becomes that area where we can provide some of that transition care? So I guess it's just ask, you know, I suppose it's keen to understand what your thoughts would be on what our approach should be on how we strengthen this now, taking the learning from this case.
I do think it is it's building from the ground up here. So as Paul said, without focusing too much on the super complex patients who are in different health boards, Bristol other side of the border and things, it's getting it right for anyone who's transitioning. So I think the idea of having that one link person, so whether they go to Birmingham or Bristol or Bridgend, if there's a link person who is named who is steering that ship with regards to just having oversight of moving from peds into adult medicine, I don't think it should be a tick box exercise necessarily, but there should be some sort of prompt, I think, in those final 12 months or whatever the age is determined to be most appropriate, that someone who is steering that sits down with the family, with the child, patient focused, and identifies how does adult medicine look to you? What do you expect from it? Is it in keeping with what we think that we can actually provide? And who do we need to link in with because of that? Because not all these people will need to come to intensive care, for example. So it will be patient specific, but it's almost like there needs to be a prompt that kicks in at a certain age. The difficulty being 16, 18, social services and all the rest of it. But I think if there is a paediatrician within the health board or a couple of paediatricians on each side who understands this model, they don't have to be an expert in gastro or respiratory or complex needs. They have to be an expert in managing a group of people to decide how do we transition this individual to the next. They don't have to be, that's their specialism, is leading the team.
Yeah, that's great, thank you.
Thanks. Dom, just very finally from me, I think going back to your point that we could return to this in about 12 months' time once you've gone through this particular piece of work. So there's obviously the learning from this example of the transition from paediatrics into adult care, which is really important, and not just for those with complex needs, but just the whole transition point anyway. You can be dealing with a child with less complex needs. But there's also an issue in the broader sense as to how we apply some of the learning around care coordination, because there'll be adults and patients and children out there who are accessing a number of different services, you know, on a week by week basis. And we know that for many people, they find that to be difficult. It requires huge navigation. There's also often a lack of sort of joined up conversations taking place within the organisation when it comes to managing those patients. So I just think there's a broader question there around care coordination more broadly within the organisation, in addition to how we make sure we get this absolutely spot on.
I think that's how we need to frame the transition programs, how we're going to do it in CTM, and start that almost being the baseline we start with. Okay. But if you give me in a year, if you're happy, we'll come back.
I was going to push it to 6 months, but if we could do it in 12 months, then that's fine.
In 5 years, we'll come back.
So 12 months. Right. Okay. Gareth, thank you ever so much.
Can I stay till the break?
Sorry?
Am I allowed to stay until?
Yeah, absolutely. Yep. No problem at all. Really good to see you. Very Thank you very much for thanks for leading that discussion with Dom. Okay, we're moving on to item 4. Item 4.1, the chair's report and the affixing of the common seal. Just in presenting the report, just to highlight a couple of very quick points. I know that the chief exec will refer to the escalation status that's been recently published by Welsh Government in terms of the improvement that we have seen here in CTM. I just want to place on record my thanks to the chair of the board, to the organisation for the continued improvement in our performance, not least in the de-escalated status in respect of finance and planning. I'll leave the rest of that to Paul. Just to alert the board, I'm sure you're aware, the Cabinet Secretary issued his priorities for this year, titled Improving Performance Together, Priority Delivery Actions for Better Health and Care. And this sets out a range of priorities for the financial year. I know that we are working through all of that to assess where we are against those priorities. Clearly, that's been based on the advice and recommendations of the Ministerial Advisory Group on performance, productivity and efficiency. And also, in doing so, I think it allows us to do a stock check as to where we are in delivering against those things the government have outlined. I know that we are quite advanced in some areas, that there may well be some gaps, but again, it's an opportunity for us just to reflect as to where we are in delivering against those particular priority areas. You will know that we have been discussing with Welsh Government the opportunity of appointing, or rather recommending to the government, the appointment of an additional associate member with a primary care background. I was very keen that the board could strengthen its capabilities and capacity around primary care, bearing in mind the enormous work that is being done by a number of different parts of the organisation, not just in terms of the hospital at home scheme, the enhanced community care work, but the work that Paul has been sharing in revamping or seeking to revamp our primary and community care offer. That actually strengthening the capability of the board, particularly around primary care, was something sensible. So the government have signed that off. So we have now pulled together a recruitment pack. We will now, subject to your approval a little bit later, put that out for advertisement in the hope that we will recruit somebody from a primary care background to join the board as an associate member. I do need to ask the board's approval, however, to make a nomination, recommendation for nomination to the Cabinet Secretary. As I said at the start of the meeting, Sally Bolt retires as of the 31st of August. Alex Brown, who is a consultant respiratory physician, has been nominated as the new chair of the clinical advisory group. And at the end of my report, I will be asking for your endorsement for Alex to join the board, and then we will ask the Cabinet Secretary for final approval. There's nothing else for me on my report, unless there are any particular questions. It's all very self-explanatory. So if I could just, in concluding my report, just ask the board to note the report. If you could ratify the affixing of the common seal as captured in section 3.1, that would be very helpful. Thank you very much. If you could ratify the chair's urgent action that is set out at item 3.2 in respect of the decision on shift patterns, that would be very helpful. Thank you very much indeed. And if I could ask you to endorse the nomination received for the new chair of the clinical advisory group to put to the Cabinet Secretary for approval, and therefore appointment to board as an associate member. Thank you very much indeed. Okay, Paul, we'll come on to your chief executive report next. Thank you very much indeed.
Thanks, Chair. Good morning, everybody. So just as Chair mentioned, just included in my report an update on our escalation status. So really pleased to say that we have been de-escalated by Welsh Government for our finance and planning criteria, which was, as you'll know, under escalation at level 3, which was enhanced monitoring, and we've now been moved down to routine arrangements level 1, so that's the lowest you can be. And that's on the back of us submitting a balanced plan for this year, as well as some of the other work that's gone on to ensure that we have a strong and balanced plan for the future. That's a really positive endorsement, I think, of all the hard work that's gone on across the organisation to try and maintain our financial position, and I think reflects confidence in government that that they can see that we are taking that agenda seriously, and that we're also making strides to ensure that we provide a sustainable financial footing for the organisation. So that's a really positive endorsement. And I think we're the only organisation in Wales around finance and planning that is at that level. So everybody else is in an escalated state for that. Also, really to say that we are still in monitoring, as you'll know, for planned care and cancer, where we remain in enhanced monitoring, and we are in targeted intervention for emergency and urgent care. I would say that I think a number of those areas at the next review, there is probably a chance that those will also be reduced. Clearly, we've made strong progress in our planned care performance and cancer, and also similarly in emergency care. We are seeing real significant improvements in our movement around the ambulance waiting times at the front door. So it's really positive to see those areas of improvement are already happening. I think we would be hopeful that those criteria for those two areas of escalation would be reviewed. Interestingly, Welsh Government have changed their process slightly for reviewing escalation arrangements. You'll remember previously there were really sort of set points throughout the year where they reviewed the escalation. They've now agreed a new structure whereby those performance trajectories are reviewed on a monthly basis. And I think if you hit 3 months in a line at the level you should be achieving, they will look at de-escalating you there and then. So it gives the opportunity for a much more sort of agile approach to de-escalation, which hopefully will serve us well moving forward. As John mentioned, the Cabinet Secretary has issued a letter or document to us earlier this month, which is called Improving Health Together. This is the culmination of really the work that he has been doing over the past few months, following the Ministerial Advisory Group recommendations earlier in the year, a speech he made to the NHS Federation in April. This document really summarises all of the key priorities that he wants to see us focused on for the remainder of this year, and obviously in the run-up to the next Senate elections in May. Nothing in there will be a surprise to anybody, because these are all things that have been well discussed within Welsh Government circles and within health boards for a long time. But I think a real focus on delivery of some of the key priority areas, particularly the primary community services agenda, which, as John mentioned, we're already working very actively on in this organisation, but also a move particularly around the digital agenda, and again, further encouragement around regional working. So I think we're in a strong position to respond to that. And there's a paper coming in a minute, Gareth, about how we've done a stock take as an organisation against where we are against the Ministerial Advisory Group recommendations. And there's also further work to align some of the accountability conditions that have come through from Welsh Government about this year's plan. So there's lots of different bits of information and ambitions flying around. It's quite helpful to have them all in one place now, so that we can actually sense check where we are against those. But in summary, I think, definitely in the right place and heading in the right direction on a number of key areas that were being managed on by Welsh Government. Sorry, 2 seconds. I've just lost my space on the agenda. Also to say that your board will know we've recently approved our people plan for the organisation, and there's a lot of work now going on to look at how we disseminate that across the organisation, with a number of events being set up across CTM to go out and talk to staff about the content of the people plan. You'll remember when we discussed it previously, it's quite straightforward in terms of trying to synthesise down a lot of complex work that goes on in this space into 4 key themes. And I think it's very opportune in a way to be able to have the occasion to go out and talk to staff about it, to explain what we're trying to achieve, to support staff to be the best they can be in their roles, but also to give the commitments as an organisation about what we as an employer will be looking to achieve to support people's professional development, their health and well-being, making sure we're delivering the things we know we've got to do to get right, but also what our expectations are of our staff in terms of how we want people to feel as a member of staff within the organisation and things that we can do to support that. Those events have just started and will be carrying on over the next month. I don't know how there's anything else you wanted to say.
Yeah, no, the only thing just to say, I suppose, is that we had one of the first of those events earlier on this week, and it was really well attended, which we were really quite pleased about. You know, people struggle, don't they, our staff to get to these things sometimes, but it was really well attended. And we had really good engagement and enthusiasm from staff for what we're trying to do in terms of, improving conditions for our teams. And I think the simplified nature of it resonated with people, and also the story that we were able to tell in terms of, what it feels like to work here when we're at our best, but also some of the things we need to improve. So hopefully, picking up on Gareth's point earlier, keeping it in language that resonates with people will help us to get a bit of engagement. But that first session was really good.
Yeah. Thanks, Carl. Also, just to update colleagues on the discussions around the nursing shift patterns, you'll remember the board had a long conversation about this in May at our board meeting and considered the various options that were presented to us by both the senior nursing team and the people team. The proposed decision that we made at that point is now going up, obviously, out to consultation, and we're in the midst of that consultation at the moment. That runs until the 18th of August. I think it's fair to say there's lots of views and perspectives being expressed, as you can imagine, through this process, both from individual members of staff, with trade union colleagues, and in various staff forums that people like Greg and Rich Hughes and Howell and his team have been going along to. And completely appreciate this is always going to be a challenging and contentious issue. We're talking about changing the working patterns for several thousand members of staff across this organisation, but we have got a detailed amount of information available to staff. I think one of the biggest challenges in this whole process is making sure people have accurate information on which to base their decisions, because it is quite complex, and trying to help people understand the pros and cons of different arrangements, what it might mean for things like pensions down the line, or things like are all quite complex topics. And there is a risk, if we're not careful, that people get run away with perspectives that have not been sense checked. So we are trying to do whatever we can do to make sure that accurate information is available to people on the internet, in those conversations that we're having, the engagement events, and obviously the feedback from that consultation and engagement will come back to the board for us to make a final decision later on in the autumn. So that's where we are on that process. And also just to say finally that obviously had news in a few weeks ago that Greg is going to be leaving us as our Executive Director of Nursing, Patient Care in early October, which is going to be a massive loss to the organisation. Greg's going to be the Chief Nurse at NHS Professionals, which is a UK-wide organisation supporting staff across the NHS with interim and bank staffing. A really great opportunity for him to undertake a role at a national level, but obviously a really big loss for us as CTM, having been here for 6.5 years as our Exec Director of Nursing and having seen us through some significant challenges and developments as an organisation. But he's here for another couple of months, so we'll be making sure we get the squeeze the maximum. There's no sort of coasting down to an exit. If anything, it's going to be the other thing, which is lobbing more and more things out. But no, plenty of opportunity to say further words about Greg when that happens later on this autumn.
So, Greg, you'll be here for the September board meeting.
Yes.
So
yes.
I shall reserve what I intend saying with that meeting.
Oh dear. Can't wait.
So they'll be very lucky to have you in NHS Professionals, and a really important body. It does huge work in NHS England, and it'd be good to see them do some work in Wales.
You never know.
You never know. Absolutely. Great. Thank you. Thanks. Any questions for Paul on his report. Catherine.
Yeah, I think mine's just a note really to say what fantastic progress we've actually made around the escalation processes, and I was noting the ambulance handover times as an example of that. I just think it's Gareth mentioned in the earlier session around the values of CTM, but I think the sort of leadership and culture of CTM is really making a difference to our population, people who live and work in our communities and improving our health services. And I'm not underestimating the challenges we've got ahead of us, but you can really see the health board changing and making a massive difference. And I think the leadership and culture of that is really fantastic. And thank you to you, Paul, and the exec team as well, and all the teams really. So it was
No, that's really
positive.
Yeah, it is really positive, and I think it's easy, isn't it, when you're in the midst of it, to forget just how significant it is and the significant improvement. And behind every one of those numbers, whether it's the planned care numbers, the diagnostics, the urgent care, there's a lot of people working really hard to try and make those improvements. And I think what's happened is I think there is people ultimately are galvanised around the fact that these are not, we talk about these things like they're numbers, well they're not, are they? They're people, and they're people sat on an ambulance, or they're people sat in an emergency department or on a waiting list waiting for an operation. And actually I think that the effort and energy that goes in at all levels of the organisation, from the exec team, care group teams, clinical teams, admin team, everybody is working really, really hard to try and keep improving and doing things better for our population. We've still got some big challenges to get through, but I think what's encouraging is it's the old adage, isn't it? Success breeds success. And if people see things improving and things getting better, then hopefully it gives them the encouragement to push on a bit further and do something a bit better again now further. So it was really encouraging. We had the Cabinet Secretary come last week. Last week to give his monthly performance update that he does to the media about the Wales-wide performance. And he chose to come to CTM, and he wanted to go to the Royal Glamorgan in particular because he wanted to see the improvement work that's gone on there on ambulance handovers. And that was really, really positive to hear from the team. It's a truly multidisciplinary, multi-professional response to that, and he was really impressed. And one of the reflections he made to me when we were walking around was what he's really learned through doing the CabSec job is all of this is about culture. And he said that's what I've really begun to appreciate in everything I've been, places I go where things are improving, it because the culture of the organisation is supporting people to improve and transforming the way care is delivered. So I think that was a really nice thing to hear from him, because he said I can see that in this team here in your emergency department. It's the team that delivered this success, and that's what this is all about. Absolutely.
And we can see that as a board, can't we? So thank you.
Thanks, Gail. Any other questions to Paul? Okay, thank you, Paul. We'll note the report. Item 4.3, the Ministerial Advisory Group report update. Gareth, thank you.
Thanks, John. And as the board will have heard it, both John and Paul in their reports kind of pointed to some of the work that's been going on in the space. But just to take you back and remind the board in terms of the Cabinet Secretary setting up this Ministerial Advisory Group during last autumn. And obviously as a health board, we played an active role and engaged fully with that review. And then the outputs that review were shared with the Cabinet Secretary and subsequently published at the end of April. I've included links to both the review and obviously the initial Welsh Government response to that report as well. It was a significant and is an ongoing significant amount of work. I mentioned in section 3 about 29 recommendations. In reality, because some of those recommendations have multi-parts to them, it's actually more than that. But what we've done is a bit more analysis on who those recommendations are aimed at, because they're not all specifically for health boards. Some are specifically for other organisations such as BHCW and HCIW, etc. Notwithstanding that, there's an awful lot of work for us and for other health boards throughout Wales to address those recommendations. So what I've included, not in the board pack papers, but in the admin control folders for the board to have a look at, is just a snapshot really of where we're at against those recommendations at the moment, because there's an awful lot of ongoing work right across the organisation. I just want to put on the record my thanks to the Cool Business Unit, Gethin's team, helped me put together some of those updates. Because it does reflect the volume of work going across the organisation by colleagues right across CTM. So that's just there as a snapshot for now. Obviously, today is the first time I'm introducing this item. We will be having regular updates on this to make sure we remain on track against these recommendations. And then to talk to, Paul's further update in terms of what's happened since then. We've had the Cabinet Secretary's speech back in the village hotel to the Confed, which, as Paul and John mentioned, was followed by the letter, which is also included in the pack, improving performance together. And again, it's really important that we remain on course in terms of these priorities which have been set out, some of which are already specifically covered within the macro bill, but I've drawn up some others, such as improving women's health, improving the openness, accountability, better prevention, and realising potential of digital and innovation. And just giving you a flavour of some of the stuff that we're already doing as a health board, even in advance of this document being shared, to provide that assurance, I guess, to the board that we're already making great strides in a lot of these areas and we'll continue to do so. So going forward, what I'm doing is I'm working with the Chief of Staff, Matthew Butt, just to make sure that we have an effective way that we can bring all of this together and report to you in a meaningful way going forward, and to give both yourselves as the board and the operational delivery committee as well, as the relevant committee, assurances really that we don't just receive these reports, we act on them. They're real documents, they're live documents within the organisation, and they will help us to meet both the ambitions of the Welsh Government and obviously the ambitions of our own organisation, but for our population. So it's just to provide that reassurance, I guess, that there's lots of work going on to address all these issues and just seeing how they all link together. Thanks.
Yeah, thanks to Gareth and colleagues who pulled this together. Again, just go back to my report, I think it is really important we've got one place, because there have been a lot of different sort of policy documents and information that have been coming out, and it has been a little bit difficult at times to keep tabs on what's the priority in which place and what we're being held to account on. So it's really good that we've got it all in one place. I think bringing a regular update here will be good, but I'm also thinking Claire and Stuart and others, as we start to look at our performance reporting as well, which I know we're doing a bit of thinking about, it. Some of these things will also feature in the performance report. So it's something about how we bring them into sort of the overall performance report and things like board assurance framework and things like that. So otherwise, there's a risk we have another set of sort of assurance processes for one specific thing, whereas actually what we really want is one performance framework, one BAF in which everything is articulated. But the challenge is sometimes we get asked about where are you on the MAG recommendations, and we need to, but something about how do we make it as easy as possible to pull off those recommendations quickly. But that's a bit of work. I know performance has been one of the areas we've talked about quite a bit at the board, but we're doing it now with Claire here as well. Having started, we're just having a bit of a think about what that performance reporting structure looks like, and we'll be building this in moving forward.
And I think from the assurance point of view, it will help the board to understand the progress that we're making, because if you think about the different range of not just the metrics that we gather here in terms of the data in today's board and in every board, there's the NHS Wales planning framework. We've got this set of priorities now from the Cabinet Secretary. We have our own strategic plan under CTM 2030. So trying to keep an eye on all of that and to do so without tripping ourselves up is quite a challenge. It is a complex environment, and I think trying to pull that together in a way that will help the board to do that assurance piece, to understand that actually we are heading in the right direction, that we are meeting the objectives that either we've set or have been set for us, and that we're confident that that's leading to improvement in the delivery of our services. So it is a challenge. And there are probably other things as well that if you look at the 6 goals program, for example, all those other things that sit in and around the things I've just outlined, I think make it quite difficult for the organisation to try and almost pick the things that we should be reporting against. But but from the assurance point of view, for the board to be confident in its assurance work, I think it's really important we try and simplify it, but just give a bit more clarity to it. Yeah.
The other thing I'll just say on the MAG stuff is, and Gareth mentioned in his report, there is a conversation going on as well about the CabSec's view about accountability meetings.
Yes.
So the Cabinet Secretary's suggested the idea of having a meeting for every NHS organisation in public once a year that he will be part of, where he will hold up health boards to account, but in a public forum. Now, there's quite a bit of discussion going on about how you do that practically, in terms of it could either be a stellar success, or it could be a little bit of anybody could turn up with any question about any topic under the sun. So there's a little bit of shaping, should we say, that the chairs and chief execs are trying to do into government to say how's that actually going to work in practice. But he's very keen that these are set up in the latter half of this year. So we will have to give some thought to that. And I guess going back to that point about recommendation, about what are we going to be held to account for in those forums. We need to try and make sure it's the big strategic topics and not right down into the weeds of, otherwise you're going to end up with Mrs. Jones from under 93 coming and ask why she's not been sorted out on the waiting list yet. And that's, I don't get it. It's a dialogue.
So the government officials met with NHS chairs at our meeting last week, and we fed back on the proposed approach. I think there is some concern and some caution about how we shape it, how it's handled, because if these are meetings held in public and the public believe that they are meetings to which they can attend, to what extent do you allow people to raise questions? This happens elsewhere in the UK. They've trialled this in Scotland. I think there was one public meeting in Scotland with more than 600 people attended. So though I think there's an issue here around balance between being able to provide a meeting in a public forum that gives some satisfaction to a public desire to be able to engage. Otherwise, what's the point of having a public meeting if people can't have a level of engagement? But whilst managing that in a way that allows the organisation to set out its strategy, set out its vision, talk about its performance, and talk about the ambition for the future, because any public engagement ought to be not just about reflecting on where we are now, but attempting to create with the population of CTM what the future looks like, and to engage people in the excitement around shaping our services for the future. So it's trying to get that balance, which isn't it isn't easy. And so the cabinet secretary's intention is that some of the NHS organisations will do this in the autumn. Others will do it in March. My sense is that those organisations who are in a more challenged position may well come to the front of the queue for the autumn. So it may well be that we're not required to do anything at this point this year, but we do have to help shape this into something that meets his expectations, but does so in a way that manages a number of different audiences. And I think that's so. It will involve, for example, inviting colleagues from Plice. His expectation is that there will be people there from the staff side to be able to give their view as to their experiences. But I think we need to do that in a way that makes good use of people's time to articulate where we're at and where we're heading. But Paul's right. There's a huge risk that it can become too focused on perhaps individual cases that are better dealt with in different environments. So, Hayley, yeah.
Are there examples in the UK that we can kind of pull on of, like, where it's happened really well and we can almost kind of replicate? We've got that.
So So myself and my peers had a presentation actually from the former Director General of the Health Directorate in the Scottish Government, so the equivalent of what we've got here. So they have shared, and they've been doing this for 19 years. So they have got a history of this, but obviously it's evolved over time, and there will undoubtedly be teething issues when you try to introduce something new to a system which is not used to this kind of model. Just to pick up on John and Paul's point, in terms of the aspiration that the Welsh Government officials are setting up a task and finish group around this. I've not heard yet, but there should be representation from my peers within that task and finish group. As I said, there's not an awful lot of time to get this up and running now, but as and when I know more, I'll definitely update the board on terms of what that thinking is, what it's going to look like, and any potential timeline.
Thanks, Gareth. I do have a particular view about the approach, and as part of the NHS Chair's response to the ministerial accountability review that took place last year, I did say very clearly that I thought the line of accountability, because in law the line of accountability is pretty clear, which is that it's me back to the Cabinet Secretary to the First Minister, and collectively to the Senate, which is why I recommended at the time that actually health boards perhaps ought to be asked in by the Senate's Health and Social Care Committee for a scrutiny session, because the line of scrutiny, the line of accountability is directly back to government and to Parliament. Health boards are not publicly accountable in the same way that a local authority is publicly accountable through the ballot box. Our line of accountability is a different route. So that was my view expressed at the time, and I thought that would have been quite a useful way of allowing the parliamentary system to scrutinise the performance of our NHS services. But that hasn't been taken up at this particular point. But I suppose that may be something that might be reflected on in the future. So we'll keep you all posted. So yeah. So okay. Thank you, Gareth. Any other questions, Gareth, on the ministerial accountability review report and the recommendations that we're implementing? No? Okay, thank you very much. If I can move on to item 5, the action log, just to present the log for noting. There are some actions that remain open. Are there any questions on the action log, any particular concerns or any other update since this was drafted? No? Okay, if I can just ask the board to note the action log 5.2. I don't believe there are any matters arising from the action log unless anybody has anything they wish to raise at this moment. Bearing in mind we've got a fair bit being covered off and delivering against our plan a bit later. Under 5.3, Board Assurance Framework, can I ask Gareth to present the Board Assurance Framework update report, which is before the board this morning for approval, and it has been endorsed by the Executive Leadership Group and was done so on the 14th of July. Gareth, thank you.
Thanks, John. Yeah. So, as you can see from the paper on this occasion, there's quite a substantive update to the Board Assurance Framework, and that's as a result of the session that we held in the middle of May, the board development session, where we had quite a detailed discussion around our strategic risks, our risk appetite, and what the Board Assurance Framework should look like going forward. So a lot of work has been done reflecting on the outputs from that meeting. I'd like to thank everyone involved in those discussions, all the risk owners, and in particular my colleague Callie, who obviously works tirelessly to put this together and make sure that it's fit for purpose and is a true reflection of the strategic risks which we face as an organisation. So the paper, I won't give a take as read, but it does summarise there some risks, a risk which we are closing, a risk which we are reframing, and identifying 4 new strategic risks, 3 of which we're looking for approval today, 2 of which are in relation to estates. And again, you remember the discussion that we had and the presentation we received on our estates from colleagues during that May session, and the 3rd risk around the delivery of integrated care model. The then outstanding risk, which will be strategic risk 9, is around our failure to plan and manage revenue and the resource limit set by Welsh Government. And we're hoping to bring that completed strategic risk to you at our September board meeting. But essentially, we're looking for approval to close strategic risk 7 and to approve other amendments and the escalation of strategic risks 6, 10 and 11, which are, as I said, as a result of the discussions we held back in May. Thanks, John.
Thank you, Gareth. Okay, so quite a significant change in the update report, particularly the inclusion of the 4 new strategic risks at number 6, 9, 10 and 11. Yep, Patsy, thank you.
Yeah, I just want to say well done. It looks really good, and particularly as it's led by the strategic objective, not by the risk, which I know I'm sad, but I think that's important. Just a quick question really on 1B, and this goes back to the Ministerial Advisory Group, setting a target of 45 minutes for handovers. And I know we've done really, really well. Everybody said that. It was one of my comments for the performance report. But But actually the target is 15 minutes in law, isn't it? So this is an interim target, presumably? They're not changing.
They're not
are they?
changing. They're not changing the national target. I think this has come on the back of some work that was done in London Ambulance Service, where they moved to say we want to get as a minimum now everybody down to 45 minutes, recognising that ideally, as you say, perhaps it should be lower than that as well. But it's not. There's not been a formal change to the target. It's trying to set sort of a new bar, I suppose, to get everyone down to. And I think then the expectation would be that you move further down towards 45. And obviously, as you say, we're doing better than that in many instances, which is good. But I think it was based at the 45 minutes, and getting correct if I'm wrong, that's where it came on the back of, wasn't it? It was the London experience in 45 minutes.
Yes, yes. So the Welsh Health Circular that was published in 2016, I should remember the date, it reflects the 15-minute handover. But yes, an interim target for this year was recommended by the urgent care group within the MAG, which was the 45-minute handover as has been established in London and is being rolled out across other systems in England. So it is a significant focus now on bringing down that tail of weight.
I just think it needs to say that, you know, that this is the interim measure
I'll
to
pick
get
that
there.
up and reflect
Yeah.
that.
No, thanks, Patsy. Thank you.
Yeah, just wanted to echo the thanks. And, this is really a live document, and this is evidencing that it's a live document, and we're treating it as such. Particularly welcoming risk 11 around the delivery of an integrated care model, and I know we've got some papers and updates on that, and we've put in a lot around that. I guess my question was more around strategic risk 10, the ability to develop a future estate, where we're saying we're treating that risk rather than tolerating it. And there is a note around the challenge around how do we get a pace of change in getting a fit for the future estate. And my question is really around: do we need to give more resource to this, or focus on this, or what is the plan? And are we really treating it, or are we tolerating it for the moment? I suppose the risk.
I would say, obviously, some of this is the treatment of that risk is dependent on having to prioritise the risks based on individual circumstances, different facilities, and the capital monies that are made available to us. That's how we prioritise on the backlog and immediate risks. The question then moving forward is also on our estate is how do we, where possible, think about, do we need the amount of estate that we've got, and how much are we spending on maintaining and updating estate that frankly is not fit for purpose and will just consume a lot of money that we should try and dispose of. And we're still having some conversations about the idea of some sort of relationship or partnership around this, because there are a number of estates, or pieces of our estate that we would probably deem surplus, and we need to think about a strategy for designing those out. But of course, it also depends on how the clinical model that's required to support that is built around that. But Sally might have another.
I suppose difficulty with one broad risk is probably that we've got a series of different approaches, haven't we? Some of which we're treating. So a huge programme of improvements at Prince Charles, a large programme of improvements at Princess of Wales, which are about treating some of our larger risks. But there are other elements where we do have a degree of toleration, and there is a crossover in terms of capital, isn't there, with digital as well. So I think it's difficult, because otherwise I'd do it by building and then you probably get a different result, but you'd have a very, very long register.
Yeah.
Thanks.
Thanks.
Thank you. Any other questions to Gareth on the update report? Okay. Is the board content to approve the closure of strategic risk 7, the escalation of those new risks, and to approve the amendments made that follow the board development section on the 15th of May. So it's terrific that following that really quite detailed consideration of board development section, we've been able to bring this updated fraud assurance framework to the board today. And I thank Gareth, Caddy and the team for the enormous year of work around that. As Kat said, it's a living document that is there to to reflect and to change, to be agile. So thank you very much indeed. Okay, we'll move on to item 5.4, the board committee and advisory group highlight reports. We've got 3 update reports this morning, and in Carolyn's absence, can ask Greg to just provide an update to the board on the Quality, Safety and Patient Experience Committee, particularly the meeting I think was held on the 20th of May.
Yeah, thanks, Chair. So we'll take the paper in your pack as read. So we had a quality committee last Tuesday, 3 items for escalation. We had a presentation from the primary community care group in relation to concerns raised around backlog of paediatric GA dental lists. Yeah. And I know we've got the dental contract on the board agenda later. We received a focus report on stroke services. The committee acknowledged the work to date, but significant improvements still remain in that space. Committee endorsed the R&D strategy, and it's on the consent agenda at the board today. And finally, as mentioned earlier, David, our carers lead, came to the board with a chap called Craig, who's a carer for his grandson, and gave a very moving story of some of the challenges it's been over the life cycle of his grandson to navigate health and social care services, very similar to what we just did this morning. So just those 3 items for escalation, Chair. Thank you.
Thank you. Any questions to Greg on the update report?
Paul? I don't normally intervene on these ones, but just the paediatric dental list.
Yeah.
I don't know if it will get covered on the dental contract. That's more of a contractual issue, but there is a real issue that we've got a large number of young people and children on the paediatric lists for dental, and I do think, well, we've got to ask ourselves what are we doing when we've got children as young as goodness knows what having their teeth all being taken out. It's a pretty sad reflection on our system. But secondly, these are a lot of children and young people who are in pain, who are sitting on lists for a very long period. And it's, as I understand it, it's just we haven't got the capacity at the moment to find the lists to put them on. So I do think we probably should try it in the same way we approach WLIs for orthopedic operations. We probably need some sort of focused effort on that dental list, but to get them very well.
I was going to come in on the GAs for Pete Dental. So there's been the challenge has been with the closure of theatres linked to the POW critical incident, and the Vanguard theatres, which we were hoping to use, are not suitable as a paediatric environment. So we've got a further meeting with the community team and the planned care team next week. So I'll happily bring the updated plan, but with the POW theatres now reopening in September, it's going to allow us to move lists around, which will then free up capacity. One of the challenges linked to this, of course, is the availability of the dentists. Because the dentists that deliver this service aren't dentists employed by the health board, they are independent contractors, and so trying to align their availability with the physical capacity within the health board theatres is a piece that we're trying to work through. But we will have a clear plan that I'll bring back to board for update.
Thanks, Catherine. I think it would just support the concerns that Paul has just raised about the impact that this has on children and young people. And despite, Catherine, the huge challenge in POW, we do know before that critical incident, we still had a significant number of children and young people waiting for dental extraction. Now, I think there are a whole series of questions as to why children get into that state in the first place. And I know this is something probably, Philip, we can pick up with the Chief Medical Officer when we meet with her on Tuesday. But it is a particular concern in this health board when you look at the numbers that we have certainly had over the past couple of years and the length of time that children and young people have been waiting. So I think any planned update would be fantastic to see on that. Thank you. Any other questions to Greg? No, happy to note the report. Thank you very much. Item 5.4.2, the Charitable Funds Committee update. Sally, I think you're going to update the board on the committee report. Thank you.
Similarly, I'll take the report as read. There's only one issue that's in the escalate section. People may remember, although it does go back a very long way, that there was an agreement to establish a staff lottery, I think actually before I started in 2021. And that stalled a little in terms of moving it forward, but is now being moved forward, but in a slightly different format. The original intention was to run a staff lottery internally, but we're now contracting it out. And on that basis, there's a change in the provision, which means the original scope was staff members only. That will now be widened by this route to include members of the public. And we just wanted to bring that to the board's attention.
Thank you, Sally. Any questions to Sally on the update report? Philip?
No, just to say there has been discussions. Obviously, there's work going on nationally with regards to problematic gambling, and obviously we're putting in safeguards in terms of how we don't encourage something detrimental to the public.
Thank you. Okay. Thanks, Sally. And item 5.4.3, the stakeholder reference group update report from their meeting on the 16th of July. Paul, as chair of the stakeholder reference group, you provide members with an update? Thanks.
Once again, take the report as read, but we have several things to escalate. There was a membership update. We had notification for the resignation from the stakeholders group of the Municipal Carers Coordinator representative, and also the resignation of the Care and Repair Director of Bridgend. We received nominations from the Deputy CEO, Head of Services of Mine to replace carers representation in Merthyr. A third sector nomination was received from Interlink, Rhondda and Taff. A third nomination was received from Care and Repair Bridgend, the new director to replace representation on the SRG. Members are endorsing this nomination and all request approval from the board. Also, the stakeholder reference group annual report. It was circulated to members for consideration prior to the meeting, and was agreed by the SRG meetings for submission to the board today. And also, in terms of reference, they were circulated for consideration. No changes were proposed. Also, was being made to the terms of reference. Members ratified the terms of reference and agreed for their submission to the board for today as well.
Thank you, Paul. Any questions to Paul on the update report? No. Okay, we'll note the report, but I need to ask the board to approve the member nominations that are outlined in Paul's report. Happy to do so. Thank you very much. Thank you, Paul. Okay, that does bring us to a break, slightly ahead of schedule. So it's 11:25 now. If I can ask the board to return at 11:40. Thank you very much.